Good evening. My name is Dr. David Doman, and welcome to another edition of Housecall. What's new with autism? Find out right now. My guest this evening is Dr. Kevin Pelphrey of George Washington University. Dr. Pelphrey, welcome to Housecall.
Thank you.
It's a pleasure to have you. You are a world-renowned expert on autism. Briefly tell our viewers about your professional background.
So I did my PhD at the University of North Carolina at Chapel Hill in child psychology, and then after that I did a postdoc for 2 years at Duke University on neuroscience, and then started my first faculty position.
Very nice. And what happened after you started your first faculty position? How did you come to GW?
Yeah, so it was kind of a long and winding road. So let's see, I started out as a faculty member at Duke University in psychology and neuroscience, and there I was doing work looking at how the human brain processes other people. And so at that point in time, this was 2003, 2004, we had come to understand a lot about how the brain processes language and mathematics and does reasoning, but something that was new was that there was parts of our brain that only process people. And those parts of the brain are very interested in what other people are thinking about and feeling, and their emotions and their intentions. And so there was an opportunity to start contributing to that literature using different brain imaging techniques that I had learned as a postdoc. And so I was kind of happily pursuing that and trying to understand the basic functioning of the human brain. And that work was relevant to autism because autism is a disorder that affects how people understand other people. And so one of the core defining symptoms of autism is a difficulty kind of understanding other people's intentions and emotions. And so I had the opportunity to study autism at that point.
So basically, this affects one's ability to have social interaction,
right,
to so-called read people.
Yep.
Okay.
Yeah, and it's that kind of very rapid reading other people's emotions and the context, the sort of subtle things that you don't pick up based just on listening to what they're saying, but kind of the subtext of what somebody's saying. And we were doing work that allowed us to kind of understand how that usually works, and then at the same time, the National Institutes of Health and other funding agencies were getting very interested in trying to tackle autism as a medical problem. And so I met a gentleman named Joe Piven, who was a world-renowned researcher in autism, and he had seen some of the techniques that we were using with eye tracking, which lets you see exactly where somebody was looking, and these different brain imaging techniques. And he said, would you like to study autism? And at the time, I really knew nothing about autism other than what was sort of in the popular press. The movie Rain Man had been a smash hit, and
sure.
So that was my perspective on autism. But I thought it was intellectually interesting, and so I started to study it, and then quickly realized it was a very, very, very complicated issue, and not something that seemed ready for neuroscience to tackle just yet. And so I kind of shied away from it and did more and more work looking at basic brain development. And then from there, I was recruited to Carnegie Mellon University in Pittsburgh. They offered a promotion to move, and it made a lot of sense. And I had grown up in North Carolina, so I wanted to live somewhere else, kind of see the world. And so we moved to Pittsburgh. And at about that time, I became a father just shortly before moving to Pittsburgh. And then as my daughter was developing, it became clear that she was developing differently. And so we're concerned about not walking on time and not talking. And so we started taking her to different specialists. And eventually the word autism came up. And I thought, well, I know something about that from a brain perspective, but I don't really see autism. This isn't what I would expect to see. And that raised for me a question of, well, how is this different in girls? Why does it take so much longer for autism to be diagnosed in girls oftentimes, and why does it present differently? And about that time, I think actually the day after she received that kind of first diagnosis, we were in shock because we had moved from a place that was incredibly rich in resources for kids with autism. North Carolina was, in the Chapel Hill area, was one of those places that is a great place to live if you have a child with autism. And Pittsburgh was an unusual place in the sense that it was actually very good for adults with autism, which is one of the very few places that's true.
Right.
But we had a young child. And so I received a call from Ami Klen, who was a famous researcher in autism, and he was at the Yale Child Study Center, and he said, we have a job, and I've been following your work and would like to recruit you. And so I actually kind of just said, well, my daughter was just diagnosed with autism. And he said, oh, well, let's stop talking about the job, just bring her out and we'll evaluate her and see if we can give you advice. And I knew by reputation that this was a place that would be an incredible place to take your child. And I knew they had a 2 or 3 year waiting list. And so Francis and I jumped on the plane and headed out.
Of course, yeah.
And at the end of that, the contract was signed, both from the point of view of getting Frances kind of the help that she needed, my daughter, and also the opportunity to take that basic understanding of the social brain and translate it into an understanding of autism, and then development of treatments that could help with the symptoms of autism. And so I was there for 10 years, and it was fantastic. I kind of went through the tenure and becoming a professor, and so Yale was a great place to be, but you can't really build a new program. It's an old place, and it's established, and it's a wonderful place to train. And in many ways, I trained in autism there. So the opportunity at George Washington was really an opportunity to build a program, and that's something I'd always wanted to do.
Right.
And a very unusual one in the sense that the chairman of the board of directors was the person who was really, of the university, who was really driving the interest in autism campus-wide. Mm-hmm. And what you really need to get a successful program going is the whole campus, to be interested. And so that criteria was there. That combined with the closeness of Children's National, and they had a very good established autism program. And so that opportunity to partner and develop something really new was very, very attractive. So,
how exciting. And thank you for sharing that personal story with us. Let's take a step back and briefly define for our viewers, in a few sentences, mm-hmm. if you can, what exactly is autism?
So autism is a disorder of development, and so it's something that we think is there at the earliest point where you can measure it. We think that autism is something that has its onset prenatally, mm-hmm. And it affects how the brain develops and therefore how the individual develops in very characteristic ways. And the kind of things that we're looking for in autism are this disruption in social interactions, so finding it difficult to understand other people. Also, simultaneously, disruptions in communication. So that can be as as apparent as not talking, or it can be really very subtle, sort of can talk but doesn't really realize, the person doesn't really realize when the other person's bored with the topic. So they'll talk about their favorite topic and not really pay attention to somebody looking at their watch.
Right.
So the other component of this is this sort of restricted range of interests and rigidity, and that's kind of at the cognitive level, very characteristic. And the important thing is that these two things kind of go together, and you don't really call it autism if it's just one or the other. We all know people who are a little rigid. We all know people who are socially awkward. That's not autism. It's that sort of very early co-occurrence and that very, well, not typical, but characteristic developmental course. It's more than a few sentences, but it's actually a really complex constellation of behaviors that you see, and you kind of say, okay, that's autism.
Now, you've mentioned some of the diagnostic criteria in terms of social behavior to diagnose autism. What are some of the current laboratory tests or X-ray studies that are being researched to have objective data to make the diagnosis? Yeah,
so right now in clinical practice, there's no blood test for autism. There's no reliable genetic test that says, you have autism. And there's no brain scan or X-ray that you can get that says this is a person with autism. In development, on the research end, all of those things are being worked on. And so on the genetic front, there's a lot of research aimed at trying to understand the genetics of autism, both so that we can develop tests that will say this person has a risk for developing autism. And it's an important point. That's probably the best we'll ever be able to do. And the reason for that is we know now that it's about 68, I think is the latest number, sort of high confidence genes that are thought to cause autism. But they always occur in the context of the whole genome of the human being. And those same genes can also cause schizophrenia. They can cause intellectual disability without autism, obsessive compulsive disorder. You think of the psychiatric condition, they also cause that in some people. And these are very different conditions. And also critically, you can have the genetic difference and not have autism. So when we say cause, what we really mean is that they tip the scale towards an atypical developmental outcome as opposed to directly cause. So there will probably never be a test that people should feel comfortable relying on that says, your child has autism prior to them being born, or even to be used in terms of making family planning decisions. It's just it doesn't work that way. And some of the things that cause autism and other things that we think of as really difficult to live with disorders are also involved in aspects of brain development that we highly value, like being very expert in a certain domain or very skilled in a particular topic, having a great rote memory, for example. And those are all things that are strengths that humans have kind of uniquely developed, but they also seem to give you this susceptibility to an atypical developmental pathway.
Hold that thought for a moment, if you could. We're going to pause for a moment for a public service announcement. More with Dr. Kevin Pelphrey, a specialist in autism, in a moment. We'll be right back.
Once there was a boy who did the same thing again and again. One day, he was told he had autism. He got help and slowly learned how to live with it better.
Early intervention can make a lifetime of difference. Learn the signs at autismspeaks.org.
We're back. My guest this evening is Dr. Kevin Pelphrey, and we're discussing autism. Dr. Pelphrey, when we paused for the break, we were discussing genetic testing to at least predict the risk of autism. So if somebody was found to have multiple genes that put them at risk, would it be appropriate to try to intervene with early cognitive therapy to ameliorate autism?
At this point in the clinical state of the art, not yet, because the presence of the multiple risk factors, we still don't know enough to be able to say that's going to lead to something that we can target as a problem for the child. We would wait, and we would wait for two reasons. One is that we don't yet have therapies that can really be used, beneath the age of about 2 years, and there's a couple of very research-oriented trials that are 6 months, 8 months, but very, very targeted, and so really 2 to 3 years. You begin to look in that second year for developmental signs that are of concern, not talking, not meeting motor milestones, and then begin to intervene. But you wouldn't necessarily need the genetic test to get you to worry. You could just be looking in terms of surveillance with your pediatrician.
Right.
I suppose that the genetic test combined with that careful surveillance with the pediatrician could help you make a decision to start earlier. But in most cases, the treatments that we're talking about, the evidence-based treatments, are all treatments that, even if they were given to a child who wasn't going to develop autism, you wouldn't expect it to cause any harm.
Right.
So it's perfectly reasonable to go ahead and start intervening.
Is it your sense, and that of your colleagues, that there's a certain flexibility, plasticity with the brain, that earlier intervention, if you do suspect autism, is a good thing?
Yeah, so the best evidence that we have from our clinical trials of the evidence-based treatments, the things like Early Start Denver model is one that's out there, pivotal response training, some forms of ABA, applied behavior analysis. Those, we know from the literature that early and more of it is better, but the literature is focused on that kind of early intervention moving into early childhood. The other period related to plasticity that we suspect, and this is a research hypothesis at this point, where we think we'll be able to make a lot of headway in intervention, is this kind of reorganization of the brain during the adolescent and teenage years. Yeah. And a lot of really exciting kind of action happens at that point, where you have massive reorganizations that are going on, and any parent of a teenager kind of can perceive this. But it's that opportunity. We as a father, my older daughter just turned 16, and so this is very relevant right now. It's sort of, there's great opportunity for chaos and change, and seeing it as an opportunity to teach her something that she might not have learned earlier. Sometimes that's harder to do because the child has so much, not my daughter specifically, but children in general, and my daughter, have so much will at that point that they might not be on board with learning this new thing. But there's that opportunity. And that's why I think we structure college the way we do, and high school, and when school starts to get more intense. And then we, I think as a species, at least in our Western culture, have organized college as this opportunity to take advantage of this very long period of plasticity that's unique in animals. We are young much longer than any other species, and our brain develops much longer. So that period from 13 to 25, for boys 42, that you have kind of this opportunity to change is very wide, and you're not really completely grown up, and that is reflected in brain development.
How interesting. Now, in your opening comments, you mentioned a dichotomy, if you will, for autistic patients that are male versus female. And that fits in nicely with now our discussion about genetics, of course. So let's go into that. What is the difference in how a male presents with autism versus women, and also what is the ratio of male to female?
Yeah. So the ratio depends on where on the spectrum, and we can talk about that kind of concept, but on average, the numbers come out at about 5 boys to every 1 girl diagnosed with autism. And I very specifically said diagnosed. So there's a growing sense in the literature among researchers that we're missing a subset of girls because we don't yet understand what autism looks like in girls. And signs of this are that for the girls who do get diagnosed, they are much more strongly affected by their autism, even though on average it's more rare to have autism. So they have to be worse, socially worse in particular for acting out and getting in trouble. And they have to have much more severe effects on their cognitive abilities, their ability to think and reason about things. So that suggests that there's a group of girls out there that might be kind of camouflaging their social difficulties and suffering underneath that quite a bit, but we don't really characterize them because they're not getting in trouble at school, they're not making a lot of noise, they're fitting in, and something about being a girl and that socialization that happens, as well as just very different patterns of social brain development in boys and girls on average, never mind autism, protects them from being diagnosed, but doesn't protect them from some of the negative consequences of having autism. And we think that those girls are actually going on to later be diagnosed with anxiety and depression and eating disorders, which are the disorders that we see, really the only disorders that we see more prevalent in girls than in boys. Girls are usually the stronger sex, particularly when it comes to neurodevelopmental problems. And so in this case, you see in autism more boys, but in anxiety, depression, eating disorders, more girls. And we think that some of the same patterns of brain development are at play, but it manifests differently in girls versus boys.
How interesting. Is it your sense that for older adults that have undiagnosed, untreated autism, that there may be an associated higher risk of alcohol abuse, drug abuse, things of that nature, to try and ameliorate the challenges they're faced with?
Yes, I think on a anecdotal sense, I think that's at play, that you've got a lot of, in adults, given how the interest and the ability to ascertain autism, we're much better now at detecting autism, and the definition of autism itself in clinical practice has widened. So what we call autism is a wider bin at this point.
The spectrum?
Yes.
Okay.
And kind of what that means is that there are a lot of adults, aging adults, who are, at this point, adults that might be in rest homes, they might be in settings that are poorly designed for autism, who are suffering from these social difficulties, not to the point where it's very clear they have autism, but we're just learning what autism looks like in an aging adult. And we only have a smaller number of examples because what used to be called autism was much more obvious. And so for an aging adult to have that diagnosis, they had to have been quite severely affected as a young person. But now, if we were to go out and do a true population study where we screened every aging adult, we should find about 1 in 68.
that common.
Right. And so given the definition that we use now, the clinical diagnosis, so there are an awful lot of people who are elderly at this point who are suffering from the effects of this condition but are undiagnosed. And a common path, again, especially for those who are finding themselves very socially excluded, and that's easy to do when you have autism, and you find yourself socially excluded, you have very little resources, very few places to turn. Alcoholism and drug abuse are one way to kind of cope with that. And it's a very negative way, but it's something that I think happens for a lot of our adults.
Let's go on to discuss other diagnostic tests. Certainly, if one did a PET scan, which measures not just anatomy in the brain, but as you know, function.
Mm-hmm.
What are some of the studies on PET scans and autism?
So under that kind of PET scan techniques and other techniques to look at brain function, there's a blossoming of studies that are taking place, from the early 2000s to now. Now we have thousands of studies that have been published. So in those, we're seeing at a group level a pattern of dysfunction in autism that is best characterized as a disrupted social brain. So there's parts of the brain like the amygdala, ventral medial prefrontal cortex for the neuroscientist watching, these kind of very strongly associated high-level thinking and applying your intentions to make things happen in the world, connected to your ability to understand other people, are disrupted in autism. We don't know at this point whether that's a cause of autism or the result of living with autism. Because remember, the brain reacts to our intentions, and even though it's driving us, it's also being shaped by us. So that's kind of the studies of autism, when you can diagnose autism. The very early studies of babies who are at risk for autism, because of that genetic risk, that heritability. So if you have an older sibling with autism, you're much more likely to develop autism. The number shifts from about 1 in 68 to about 1 in 20. And so you have that risk, and that has led our group and other groups to follow those babies very early in development over time. In those babies, parts of the brain that are involved, again, in social information processing, but also in long-range communication between centers of the brain that do specific things, are shown to be disrupted. And that developmental profile predicts which kids will develop autism and how bad their autism will be.
Great. Well, I'm sorry to cut you off, but we're out of time. So if our viewers have any other questions about autism, how can they reach you?
So the best way to reach me is by email, and we have an email that gets to our Autism Institute at GW, and I believe the viewers will be able to check that out on the screen and write it down. That's always the best way to reach me, and usually I try to respond to that within a day or so.
Excellent. Well, thank you for joining us on Housecall.
Pleasure.
My thanks to Dr. Kevin Pelphrey for an excellent interview on autism. My thanks to my team here at the station, and thanks to you, the viewer, for welcoming us into your home. Tell us how we're doing. You can reach me at my practice website, montgomerygastro.com. As for our next show, it's going to be a fascinating one. Dr. Elizabeth Nichols of the University of Maryland Medical Center will be discussing gamma pod treatment, a new treatment for breast cancer. See you then next time for another edition of Housecall. Good evening.